Hip.
Okay, I started the video. Okay, what do I do for hip? Okay, lie down on your back. Yeah. I mean, like when I think about like any of the moves, don't think too much specifically about the technique itself of the mobilization. Like think about what you're restricted in, right? For example.
Okay. Just mostly flexion, yeah.
Yeah, like if flexion you're limited, then you go into flexion. But it depends on where you're limited. If you feel like you're limited right through here, that would be what we call closing angle joint pain. So if you push too far into that, you're just gonna irritate it, you're gonna jam it. So a lot of time we look at, you know, for
IR,
IR or ER, that gives us a lot more information. Because when your internal rotation is a little bit more limited, so you want to move into that direction. Again, we never want to push beyond that pain threshold, right? So when I just go oscillate nice and easy, you might go into a little bit more flexion or adduction.
That feels a little bit more tighter.
Yeah, and you feel it on the inside?
More over here.
Okay, that's a good thing. That's not a closing angle, right? Well, that could be your pen. That could be a pen poking you there. But yeah. But a lot of time when people feel that closing angle joint pain, you better get in there with your hand, work on those
to
structures.
help it feel a little bit better.
Exactly,
So
yeah. You're not getting rid of anything, you're just making that feel better. And then you work on like pails and rails. So internal rotation, you push that way out into,
Should I go
push
do it actively?
Yeah,
Oh, okay,
yeah.
go ahead.
Yeah, and then that's a pails contraction, progressive angular isometric contraction. Okay, and usually 10 seconds and now hold that position. Yeah, and push
And
it
then
up.
go up.
Yeah, so that's the rails. You'll feel it right through the outside.
So the pails is the first one, and then
Yeah,
rails,
rails is the second one. Yeah.
me actively doing it.
Exactly. Yeah, because they're isometric contraction in different positions. So now nice and relaxed. I shouldn't measure you, but usually I measure your active range into internal, whatever degrees. Usually after 3 rounds of pails and rails, it should improve. So it's like good now. It's more. Yeah, pushing in. Yeah. So I don't even think like for the hips, I don't even do a lot of manual moves. I'd rather spend my time doing like active stuff like this, and you're gonna see. For me, so far, I've seen way better gains out of this. Yeah, hold that position again. Pushing up. Okay, good. Yeah. So just depending on how you set up your body, I guess.
But I think I've been doing this even with my CP patient.
CP?
CP.
What's CP?
Cerebral palsy.
Cerebral palsy. Okay.
Spastic, yeah. Because I was thinking as well, it's like if I'm gonna be doing stretches, it doesn't make sense.
No.
And so I'm thinking of mobilizations and manipulations because that's where I kind of let them buy into it first, and then it slowly introduce the pills and rails.
Yeah, exactly. Yeah, you gotta do some passive stuff with
That especially what their expectations are. You know?
Right. They're like, I can't even do anything. I have these neurological conditions. Why are you asking me to do movement? Yeah, it doesn't make sense.
But in patients in general as well.
Yeah.
But how do you
get that buy-in?
Yeah.
Literally, I would be like, here's my goniometer.
Oh, okay.
Yeah, like whatever your range
the ones
is.
that you did.
Yeah, and then like do that, and then like measure again. Okay, usually I see a good like 20%, sometimes 30% improvement. Like, and then I use terms like, look, your investment is not gonna give you that percentage return in like 2 minutes.
Yeah.
Right. And
you have to
then
do it
they kind
consistently.
of and then they kind of laugh a little bit, but basically I'm trying to say, within 1 minute, 10-second push, 10-second hold, times 3, that's 1 minute. You can gain like 20-30% range. Imagine if we did that regularly, or imagine if I showed it to you, and then you do it at home regularly. How much gain are we gonna get?
That's
probably a lot more. And then you tell them that there's gonna be a physiological limitation at some point. You're not just gonna keep improving.
Yeah, at some point it has to plateau.
Exactly. Yeah. So that's where like FRA comes in, because it really gives you some idea like how to assess those ranges, and then how much is enough. Sometimes we don't know. It's just like very sport or patient dependent. Right?
But do you do any mobilizations?
Yeah, like like so bouncing at the end range is a mobilization, but you could do like something like this, where you're laterally gapping, or like doing an inferior lateral, or like inferior, or not posterior,
try that
posterior, inferior, You can get into more flexion. You can just kind of play around, find the area of restriction. You just kind of want to go sometimes away from it, sometimes into it. Yeah. Because you think about the hip, right? With the open tack position, like external rotation at the slight, right?
Yeah.
Yeah. So sometimes you might want to mope into those positions, but not always. Yeah. But in this position, the hip is just more clear those things. If it's in IR, you're gonna get more of that impingement type of position.
Do you do any HVLA for the hip now?
Right? Like hold on to the table. So you kind of grab onto it, have that hip into slightly open tack position.
Pretty much the same thing.
Yeah.
Okay.
So.
How about for the knee, Dr.
The
Jason?
knee, I could use the toggle board, or you can just go into whatever position. If you like extensions a little limited, get a little balance. There is like a fibular head adjustment. You want to like use your what we call the piezophone contact. You just kind of find a position, give it a little thrust, depending on this. But
pretty much going into extension.
Yeah, because the knee most of the time is limited in extension when you have a major injury. Well, flexion is too, right? But flexion, if you do that, like it go to end range, you could, yeah. And just it's not worth it. Better do pails and rails, to be honest.
Yeah. Okay. And I want to try those I know I can't do it, but like
lumbar adjustments and stuff.
Lumbar adjustments and then some.
Yeah. I'll show you. You can try it on me.
Yeah. And
now go on this side.
Yep.
That's me. Yeah.
Same.
Yeah. So you just want to set up. You want a good amount of hip flexion, and then tuck that bottom hip over. There's different like procedures. Some say you do not torque the area. You do not torque the lumbar spine. Some patients say you want to stack the top. Yeah. I just torque it, get a little bit more end range. Because with high velocity, low amplitude thrust, you have to take to end range first.
Before you can. Okay.
Yeah. Otherwise, it's like you're going into like too much freedom. Right?
Yeah.
You want to lock it up. That's the term we use.
So tight first.
Yeah. So lock it up. That's your end range, and then just go a little push.
Yeah.
Okay. Sometimes I give two thrusts.
So where do you push it? Like
I use my body to drop, so I'm not using my hand.
Yeah.
So you want to
push it in.
Yeah. So you kind of use your hand to guide this area, but it's my ribs that's making contact with your body. You could also my legs there to control it. So there's a longer lever. Versus I use my hand, that's a really short lever, right? Because I use your leverage of your leg to
go into end range. So
yeah, exactly. So I can even do like something like this, right? If I want a longer lever, I do it.
Yeah, I saw people do that as well.
Yeah, exactly.
So get it into end range. So hip goes into internal, or no, not really internal, but like
flexion and then slight rotation.
And then this top here.
Yeah.
You just go into that.
So again, I just kind of hold it here.
Just
Some people say they distract this way. I just kind of hold it there so they don't fall down.
Yeah.
Right? And then I just get on top and I drop. Yeah. The drop, it cannot be like I'm coming up and then boom, I drop. That would be a
drop very.
Yeah. So you just kind of go here, slide drop. Yeah.
And this one just goes in.
It kind of just rotates, yeah, because that's how you gap that joint.
Okay.
So
trying to I want to try. But I'm trying to piece it together. So put into end range first.
Yeah.
This one. So okay. Then pull in a bit. Then side my stack.
Yeah. You could stack or not stack. So like I just get the patient to stay here, but you could stack. They say when you're stacked is more so for the SI, but that's kind of not true, right? Because it can't be that specific. You could try to direct it into the SI.
And then here, I just put that right there.
Put this hand underneath here. Sometimes I like to put your hand, like get the patient grab the elbow, you put your hand on my hand.
So as not to...
You go this way. You kind of hold me there. Right?
So it doesn't go sideways.
Yeah, exactly. And then even the contact, you want to have it over a little bit more. You want to be close.
You want to be pushing it in while I'm pushing down with my wrist.
Yeah, so you're kind of rolling me over.
And then
you drop. Yeah, so you want to have your bum lower. So think of it like a squat almost, like, yeah, so that way you're using a core, you're not like hinging just at your lumbar spine. You're
So
dropping your
in
whole body.
one go. So
Yeah.
oh wait,
Yeah.
like that first.
Yeah, just tight and then you drop.
Okay.
Yeah,
Kind of like that.
That was just was yeah, it was a good, like the technique was good, and
Whoa.
the only thing missing is the speed, right?
The speed, okay. Yeah, I'm trying. It just feels kind of awkward. for
Weird,
me.
yeah.
Yeah.
It's a new skill, right?
Or maybe it's no.
Yeah.
So push it with the ribs
Yeah.
down.
Yeah. Try this side because you gotta be good at both sides too, right? Yeah.
So pull first, and then I'm gonna be
Yeah.
doing that.
Yeah. Use your knee as leverage, sort of bring it down.
I'm not sure if I can.
Yeah.
do
Yeah.
that.
Yeah. Or you can just do that and then you
I might
set
lose
your leg,
balance
yeah.
for this one.
Yeah. Have your right hand more centered toward the spine.
Here.
Yeah. Yeah.
And then push it.
Yeah.
Kind of like that.
That's not bad. Have you done this before or practiced?
First time.
First time, that's a good technique. Yeah.
But I wasn't able to adjust.
I'm not easy to adjust either.
Yeah.
So yeah, I'm not very easy to adjust.
And
So-
I've also
Watching the camera.
I've also noticed that the chiropractors would ask me to inhale and exhale, just
Yeah.
for you to.
For lumbar, I don't necessarily need to,
Yeah.
but it's more so for the thoracic. I'll show you the thoracic one. Yeah. So lie down. Yeah. So facing upward.
I'm trying to piece that together.
Yeah. So usually for thoracic, slide down a little bit lower. You want to, yeah. And then you want to get the patient to bend both their knees. Sometimes I do, sometimes I don't.
Kind of depends on-
Yeah. I always like to cross that side over because it's easier for me to control versus like this. It's harder for me to control.
So opposite
Yeah.
over.
Yeah, but it doesn't really matter. You get
Oh,
the
okay.
patient to just hug their shoulders, or sometimes they're just nice. If they're too loose, it's hard to, yeah. And then I
And
just
then turn.
I like to do a fist contact like this. I put your spinous processes in the
Directly into
yeah,
it?
in the
Okay.
in the gap, and then I can just kind of feel for that. Okay, that's the spot. I
So
want.
directly over.
Yeah, I'm almost like pinching your. Yeah,
Oh, okay.
almost pinching. Yeah, and then I'm going over and make sure I roll you over I roll over my contact. If I'm adjusting
You
here,
even feel it?
I'm over there. If I'm adjusting lower, if my hand contact is lower, I gotta be down here. If I'm adjusting even higher up, I gotta be over top. So from here, I'll give you a thrust. So I'll have you taking a deep breath and breathe out. So as you breathe out, I go over once you're pretty empty. I give you a thrust. Yeah. One more deep breath in and out. Okay. Yeah. So the CT area is harder to get. There's different techniques.
So spinous process directly over it,
Yeah.
and you hover
Yeah.
on top if you want to adjust the top portion.
Yeah. You lean your body higher up.
If you want to
Yeah.
adjust the.
Yeah. Essentially, you just want wherever you're adjusting, you want your center of mass directly on top of it, right? If I'm adjusting lower, my hand contact's lower, but my body weight is lower as well.
And then does it matter where you?
Well, your hand, you have to shift your hand too, right? So it's just that sometimes, like as young practitioner like myself, before I don't get over my contact. Like my body is down there, even though I'm adjusting up here. So you want to move your body over top.
Okay, I think I.
Yeah.
So
Yeah.
tight, nice
Yeah.
and tight first, and then turn.
Yeah. Yeah. See if it's comfortable for your hand. Yeah, and then roll me over. Roll me back over. Yeah. Yeah. How's your hand?
I think it's on the side now.
Yeah. Yeah, so you have to find my spinous processing. Yeah. Yeah, contact, and you just give it a drop.
Okay, I think I see.
There you go.
Okay. Oh shit. Feel like a Cairo now.
Yeah. Deep breath in. Yeah.
I think it was more in the
As a
one set.
medium
Was it?
velocity, high amplitude.
I'm sorry. Medium velocity.
High amplitude thrust.
Medium
The speed was not fast enough,
Okay.
and the depth is too much.
Too much.
Yeah.
Okay. The depth where I went in, or just
Where you went in, I guess. Yeah, it might be okay. It might be okay. Yeah.
okay.
Yeah,
all right.
because
I have to work on that
yeah, because when you take the end range, you don't need a lot to get them beyond
because it's
that.
on
right?
the end range.
Exactly.
So I went in too much.
Yeah, yeah. So you just
need to
carry.
control.
It's like you just
I need to control it.
end range here, boom. That's it. Sometimes people are end range, boom. That's how you just.
That's what I did.
Yeah.
Oh,
That's
okay.
how you fracture patients' ribs.
Ah. Yeah, need practice. Okay.
Yeah, so.
All right. I'm gonna continue this.
Yeah,
because
sounds
this-
good, no problem.
I've learned 3 or 4 things.
Yeah, there we go.
Okay.